Welcome, everyone, to our webinar, Cervical Cancer Prevention, Recent Progress, and the Unfinished Agenda in Low and Middle-Income Countries. My name is Scott Whitted, and I work on advocacy and communications for cervical cancer at PATH in Seattle, USA. And I'm very proud today to be sharing a virtual stage with three international experts on the topic who will be sharing a lot of the interesting data with us. Before I introduce our speakers, a little bit of housekeeping. If you don't have your computer speakers on right now, you can't hear me. So I hope you'll read the note and turn them on. Even if you do have your speakers on, you won't be able to use your microphone today. To ask a question, please use the chat window on the bottom left corner of your screen. You can submit questions anytime during the session. We'll be collecting them here, and then we'll respond to them in the last part of the webinar. This webinar will be archived online, both the slides and the audio, and when we have that up, we'll send a URL out via our HPV Flash newsletter. If you haven't subscribed yet, you can do it by requesting at that email address at the bottom of the screen, and I'll be sharing this information a little bit later on too, so you have a chance to jot it down then if you'd like. So as I said, I'm really proud to be with three colleagues and friends, Dr. Daniel Murakura, Dr. Partha Basu, and Dr. Vivian Su. I will introduce each of them in more depth just before their presentations. Also want to point out that there is available a supplement to the International Journal of Gynecology and Obstetrics. It's free download. You can download the entire journal or individual articles at that URL at the bottom of the screen. And again, I'll put this slide up at the end so you can have a chance to jot the URL down at that time. So cervical cancer, it's not a mystery how to prevent cervical cancer. We know what to do, and we know how to do it. We've got fantastic tools, effective HPV vaccines, and feasible and affordable pre-cancer screening and treatment modalities. And we know how to use those tools in low-resource countries. We've got a lot of operational experience and lessons learned from many different countries. Another very exciting outcome is that we have expanding partnerships now. Especially there are new stakeholders joining the fight who are very concerned about the health of women who are HIV positive. As well, the United Nations has recently convened a new coalition, a partnership of 7 UN agencies interested in cervical cancer. So we have great hope that good things will come from that new coalition. Where we really need to do more work is on generating political will and funding. Political will, especially at the country level. Ministries of health need to be adding cervical cancer prevention to their portfolio of services, and both legislatures in country and legislatures need to allocate funds, line items in the Ministry of Health budget for cervical cancer, and international donors need to step up and help the countries to scale services to population levels. So what's the vision for cervical cancer? Well, 25 years ago, people didn't have much hope that we could do much about cervical cancer in low-resource settings. Pap smears didn't seem to be, it was not possible to roll them out at population scale due to technical challenges. Well, that was a long time ago. A lot has changed in 2.5 decades. Now we can see an end to the suffering and mortality caused by cervical cancer, and we're calling for elimination. And Dr. Su will talk much more about that at the end of the program. What's the burden of cervical cancer? Well, a woman dies about every 2 minutes somewhere in the world from the disease. There are over 260,000 deaths per year. HPV vaccination is fantastic and holds great promise, but many women still need screening. There's a backlog of over 700 million women in low and lower middle income countries now who need to be screened in the next decade. The burden of the cancer falls mainly on the poor. 85% of deaths are in low-resource settings. You can see that from the chart on the right there. Mortality rates, for example, in Eastern Africa are much, much, much higher than in Australia. And cervical cancer is the leading cause of cancer death among women in 38 countries, mainly in Africa. The good news is that prevention is effective and cost-effective. In fact, the WHO a couple of years ago said that visual inspection screening for cervical cancer was a public health best buy and strongly recommended that countries take it up. This cost-effectiveness is especially true in populations with large numbers of HIV-positive women. It's those women who are at the greatest health risk. And the platform to serve them is already in place, so integrating cervical cancer prevention should make sense. Thank you so much for your patience in listening to my opening comments. Now I'm very excited to introduce our first panelist, my friend Dr. Daniel Murakura. Dr. Murakura is a senior obstetrician gynecologist who holds a Master of Medicine in Obstetrics and Gynecology from Makerere College of Health Sciences. He spent over 17 years working with various partners in primary and secondary prevention of cervical cancer in Uganda and other countries. Dr. Murakura has an interest in cervical cancer research as well as in country-level policies and programming for scaling up new cervical cancer prevention technologies. Dan, can you please take the stage?
Thank you very much for the kind introduction, Scott, and welcome listeners to this webinar. I'll be taking you for the next few minutes through the existing powerful tools for prevention. We know, and I think the world has been blessed for having the HPV vaccine identified in the world. And we know that HPV vaccines are safe and effective, and they are nearly 100% effective in preventing HPV infections for the serotypes for which they are targeted that result in precancer. Current data that is available has shown that actually there may be no need for a booster because we see that they seem to be long-lasting protection. It also has a very excellent safety profile. For example, more than 200 million doses have been delivered, and we've not seen what could cause concern. The WHO has made HPV vaccine recommendations back in 2009, and we have had nearly 10 years of experience with this vaccine. Currently, the recommended dosage is the 2 regimen for the bivalent and quadrivalent, and this definitely significantly reduces the cost of delivering this vaccine. The challenge we still have is that only 1% of eligible girls have been reached worldwide with the vaccine, and I think that is something that we should be putting into consideration. So the HPV vaccine has very good potential. For example, the impact on immunological and disease endpoints surpasses expectations. And where HPV vaccination has been done, we've seen cross protection, particularly for HPV type 31, 33, and 45. And we've also seen herd immunity, which gives this potential for, if it's given massively across various communities, we may be able to see significant reduction in new cancers and therefore prevention. Of course, there's a new 9-valent vaccine currently used in the US. It may still have some cost issues, but the good thing is that it will be having ability to cover more serotypes that may lead to cancer. Significant price reductions have been observed for the bivalent and quadrivalent vaccine. I think currently Gavi pays $4.5 per dose, and we know that PAHO has a revolving fund or negotiation for prices in that region. And we have new manufacturers that have come on board. And this increased competition, we think, and believe that the pricing of these vaccines will come down. Pre-cancer prevention has been one of the largest interventions that we've had for several years. We know that persistent HPV infection can lead to pre-cancer and cancer, and screening with treatment of pre-cancer is highly effective for preventing progress to cancer. Available studies have definitely demonstrated this, but unfortunately only a handful, if I could use one handful, very few women have access to screening in the low-income countries. Of course, with organized screening programs in the wealthy countries, we've seen that there has been dramatic reduction over the last 4 or 5 decades, the dramatic reduction in the incidence and prevalence of cancer in those countries. So we still have a backlog of women who are unscreened, and we know that without increased screening by year 2030, we'll have an increase in the deaths to at least 700,000 per year. There are new technologies. They are inexpensive, particularly VIA, and I think Scott mentioned earlier that WHO mentioned that VIA is a best buy. These have been proven in various countries. Unfortunately, most of these have not been taken up to scale. I know that in my country, for example, in a recent assessment, only up to 10% of women are able to access screening. VIA is a very good starting point for countries in various programs, but it provides a very good platform on which we could integrate other screening options. HPV DNA testing is highly sensitive, and we know that its sensitivity rates are double to the VIA or PAP. Screening and treatment recommendations, various organizations, the WHO, ASCO, have all come up with guidelines that all have consensus that primary screening method should be HPV DNA, where it is possible and affordable to implement. But of course, HPV DNA cannot be introduced in isolation. It still needs a VIA platform that will guide for treatment decisions. There have been various studies for the last 10 years where HPV screening has been studied, and I think provides a very good option for the HPV test. It has various advantages. They can screen themselves, can provide the sample, and so you can reach very many women efficiently. It has very high acceptability, so you eliminate the need for a woman to come to the clinic for an HPV, for a speculum examination. And among providers and families, this has been found acceptable. And of course, this significantly increases participation and also eliminates the need to occupy the health provider who may have a lot of other actions. So you can imagine that if you have a prevalence of, say, 10% of women with lesions, you will have reduced the number of women that require to undergo a speculum exam and then focus on only resources on those ones who may have a problem. There are new treatment modalities available, and however, there is still more data needed in the management algorithms for screen-positive women. Treatment of cervical cancer often is the weakest component, especially in low-income programs. We know that various partners have initiated programs for screening, but they still face lots of challenges, for example, in having the inputs or the equipment for treatment or a weak referral system. So ablative treatment promises very good success, particularly cryotherapy and thermocoagulation, because in terms of effectiveness, we know that up to 85% of high-grade lesions can be eradicated. The safety is very high. We have low rates of side effects, And it's very relatively easy to use, particularly in areas where we don't have access to doctors or gynecologists, but we have many midwives or other local cadres that can be able to use this equipment with ease. And therefore, it's very easy in most of the lower levels of the health system in the low-income countries. Currently, there are several devices coming on the market, particularly for the low-income. Some of you have known the LIGA for cryocoagulation, and then also other devices for cryotherapy. And we think that all these devices make it possible for us to be able to scale up treatment in all these areas where we are working. It's been a pleasure speaking to you, colleagues. Thank you very much.
Thank you so much, Dan, for an interesting presentation. I'd like to remind everyone listening that if you have questions, please type them up in the chat window. We're collecting them now, and we will present them a little bit later on. I'm very pleased to move on to our next speaker. Sorry, I keep hitting the wrong button to move the slides. There we go. Our next speaker, Dr. Partha Basu. Dr. Basu is a medical officer at the screening group of the International Agency for Research on Cancer in Lyon, France. Dr. Basu has been involved in a number of studies to evaluate alternative cervical cancer screening tests, alternative treatment strategies for cervical precancers, and prophylactic and therapeutic HPV vaccination in low and middle income countries. Dr. Basu, we're anxious to hear your presentation.
Thank you so much, Scott, for the kind introduction. Just now we listened to Dr. Daniel explaining the availability of two very effective and feasible tools to prevent cervical cancer, especially in the developing countries. And these are HPV vaccination of the pre-adolescent girls and screening of the women for cervical cancer starting at the age of 30 years. And together, they have the potential to eliminate cervical cancer. As we can see here, substantial progress has been achieved in the developing regions of the world to introduce the HPV vaccine. The vaccines were the first vaccine to target any cancer, and it has seen a rapid translation from the bench to the national immunization programs. The randomized trials, the results were published in 2006, and in the very next year, the vaccine was introduced in the National Immunization Program of Australia. The WHO recommendations in 2009 about the safety and efficacy of the vaccine, and then the subsequent support by the Gavi Alliance in 2013. Many developing countries, they were enabled to initiate their demonstration projects and or introduce the vaccine in their national immunization programs. And currently, more than 100 countries, they deliver the vaccine to the national immunization programs, and 43 LMICs are included among them. And many LMICs are on the list to initiate the vaccination program within a short period. Sorry. I'm trying to go, yeah, sorry. Okay, so this slide shows the current status of HPV vaccination around the globe, and remarkable progress has been made by the South and Central American countries, where 80% of the eligible girls, they have access to the vaccine through the national immunization program. That's a huge development for the developing regions of the world. Interestingly, the HPV vaccination performed reasonably well in most of the developing countries, especially in the demonstration programs or even in the national immunization programs. Let us take the example of Malaysia, where a very high coverage of all 3 doses was achieved in the first 5 years of the program. As you can see here, the coverage is exceeding 95%, and then this is even better than the coverage achieved in many of the developed countries like United Kingdom or Australia. So The same kind of phenomenon was observed in the demonstration programs or the national immunization programs in Bhutan, Bangladesh, Rwanda, Senegal, etc. So this is very encouraging, and this proves that the vaccine is feasible and acceptable in the developing worlds. So in the last decade, the screening tests like visual inspection with acetic acid, which is also known as VIA, or the HPV detection tests, they have been extensively evaluated as alternative to cytology, especially for the developing countries. And many developing countries, they have initiated national cervical cancer screening program using these tests, as you can see in this slide. So some of the, quite a few of the Latin American countries, some of the sub-Saharan African countries, and some of the Asian countries, they are either using the VIA or HPV detection tests, and some of them are still continuing with cervical cytology. Let us take the example of Bangladesh. In spite of many challenges, the VIA-based program in the country is being gradually expanded from the secondary levels of the health services to the primary settings. And this has improved the access and the coverage of the program gradually, starting from a pilot project, and this project is now being expanded all across the country. And in all the districts the program is there, women have access to VIA screening, and there is a good number of colposcopy and treatment centers which have been established to ensure that the VIA positive women, they have access to colposcopy and treatment. But then the challenges or the barriers faced by the program, these are very typical and then something which is expected in any low resource setting. The major problem is lack of an effective health information system. And without an effective health information system, monitoring of the program, ensuring quality assurance, these are quite challenging. And this program, interestingly, also highlighted the difficulty of sustaining cryotherapy in such kind of setting due to inadequate supply of gas. And that is why the new ablative technologies like thermocoagulation, they have probably a lot of importance, and they should be more evaluated and utilized. In India, as a contributor to 1/4 of the global burden of cervical cancer, till now only one province has been able to introduce a mass-scale VIA-based program. And then in this program, a major achievement has been to have an effective health information system, which was developed with support from the World Bank. And each woman is given a unique ID, and these different levels of services are linked to this unique ID. And this has considerably improved the performance of the program. So this highlights the importance of having a health information system within the screening programs. Some of the countries with high burden of HIV or AIDS, they have leveraged the HIV control program to provide cervical cancer screening services through the ART centers. And this is not only limited to the HIV-infected women. Such kind of services are being now expanded to the general population. A nice example is what they did in Zambia. They initiated the cervical cancer screening in 2 ART clinics in Lusaka, and also ensured that there is a lead clinic for the treatment of those women who are not suitable for ablative treatment. So starting from a nucleus, as you can see here, gradually over time, the facilities are being expanded around the country. And similar kind of model is now being followed in other sub-Saharan African countries like Ethiopia, Kenya, Malawi, Tanzania, etc. So the developing nations, they have several new strategies to tackle cervical cancer. But then there are also many challenges to be met, especially in the face of the competing health priorities in these settings. And cervical cancer prevention is an important milestone to achieve the goals for the sustainable development. This has attracted its due recognition of the national leaders and the global health communities. So hopefully over the next decade, we'll see a substantial reduction in deaths from this dreadful disease, if not an elimination of in at least some of the countries. Thank you very much.
Thank you so much, Partha, for a really interesting and data-rich presentation. We really appreciate it. Quick note to my co-presenters. If you're in full screen mode, you may not be able to see the chats that are coming in, so you might want to go get out of full screen mode to be able to read the chat. Okay, now let's move on to our final presenter of the evening, my colleague from PATH, Dr. Vivian Su. Dr. Su is Associate Director of PATH's Reproductive Health Program and Director of its cervical cancer programs. Her work in women's cancers has spanned more than 20 years. Among other achievements, Dr. Su headed a team at PATH that collected groundbreaking data on the feasibility of delivering HPV vaccine to young adolescent girls in low-income countries. She also served on a Gavi team of advisors on HPV vaccination and was a member of the steering committee for the development of WHO guidelines for cervical cancer. Vivian, please take the floor.
Thank you, Scott, and it's good to be here. I welcome all the participants who are listening in and our co-panelists. As we heard from the previous speakers, a great deal of progress really has been made, but there is still more work to be done to be sure that all women in need can benefit from these advances we've been hearing about. So when I started working on cervical cancer, actually about 25 years ago, I never imagined we would be talking about eliminating it as a public health problem. But when smallpox was eliminated in 1977, it really triggered a recognition of the power of vaccines, and it ended up launching the expanded program on immunization and a whole range of national immunization programs. But at that time, not all the tools for childhood immunization were there, but they had a clear vision of what could be done. We already have the tools for cervical cancer prevention, and so we're in a much better position to take this knowledge and move towards elimination, as happened with that killer of smallpox. We also have a growing awareness that cervical cancer prevention is especially critical for the millions of women who are living with HIV. Those women have a higher risk of acquiring HPV infection and also for a risk for progressing from that infection to cervical cancer more quickly. So it's especially important that we help and ensure that HIV-positive women get screening. But that's not enough. For us, the target is clear that even when we start with HIV-positive women, ultimately we must reach all the women who are at risk and eliminate cervical cancer as a public health problem. A critical issue to consider, which we haven't mentioned yet today, is what all of this effort would cost. The journal supplement issue that Scott mentioned at the beginning includes an article which analyzes this issue of cost. Nicole Campos and her colleagues at Harvard calculated the cost of a basic program that included vaccination, once-in-a-lifetime screening, and cancer treatment. And they added that up for the 50 low and lower middle income countries over a period of 10 years. The figure they came up with is that it would cost just over $3 billion over those 10 years to vaccinate 160 million girls with 2 doses of vaccine. and also to screen and treat 170 million women who are eligible of the age 30 and older for screening. With an investment at this level and the combined efforts of national governments and donor partners, we could see an amazing impact in just 10 years. This kind of effort would avert just over 5 million cases of cervical cancer, preventing nearly 4 million deaths that would occur, and a staggering 22 million disability-adjusted life years, or DALYs. We get so many adjusted life years because this cancer affects women in the prime of their life, when they would have had many years of healthy life remaining if the disease could be prevented. So we know that investment in prevention could avert a substantial burden of disease and still provide good value for public health dollars. So this article that was just done really reaffirms the initial recommendation from WHO that this is a best buy. If we, however, continue to defer action, the cost of not acting, if we are waiting for better technologies or for successive cohorts of vaccinated girls to grow up through the system, we may end up by sacrificing the current generation of women and also those girls who didn't have a chance to benefit from HPV vaccines. So it's a critical decision that we need to make. To make these opportunities a reality, 7 key actions have been identified by leaders in this field. The first thing is that we have to focus on scaling up what we already know. We've made so much progress, but as both Dan and Partha had mentioned, this progress hasn't gone to national scale. It's mostly in small pilot programs. We have a few countries like Bangladesh and Zambia and a few others in Central America and Argentina that are gradually expanding these programs and gradually reaching more women. But there are many more places where that has to happen. The second thing is that we need to seek synergies and increase integrated services. We heard the mention that how important it is to build, for example, on the services for HIV positive people. And those services are in place. Family planning services are already reaching women. And we could find great synergies by integrating some of these services for these same groups of women, making it more convenient for them. For adolescents who are beginning to get health services, making sure that they get immunization with HPV vaccine. These are ways that we can extend the value of our investments and be sure that we have made services as convenient as possible to remove some of those barriers. The third thing that is needed is to create linkages, better, stronger linkages between screening and the women who need precancer treatment and cancer treatment. And we heard mentioned earlier that we often will lose women who will make the effort and come in and get their screening, find out that they are positive, but treatment may not be available for them right away, or the health information system may not adequately serve to get them onto services. So that's something we need to work on in every country, strengthening those referral ties to make sure that women who are screen positive receive the life-saving treatment that they need. The fourth thing is we need to make some progress on pricing. You heard that we have brought the price of HPV vaccine down. Gavi, the Vaccine Alliance, is able to buy HPV vaccine for $4.50 a dose. That's $9 for the 2 doses. That's a huge drop from what it was when it first came out and what is still the price in high-income countries where it's more than $100 a dose. But we are not having that same kind of benefit for middle-income countries, most of whom can't afford $100 a dose. So they need to be able to negotiate that better pricing as well to serve the girls in their communities. And we also have some equipment that is needed for screening and treatment, some of the ablative equipment that Partha mentioned. And by pooling maybe purchases, we should be able to bring down the pricing to make that more affordable for countries that are ready to scale up their programs. The fifth action we need is to increase the confidence that is there in the interventions that we have at hand. That's both among policymakers and among the public. We know with cancer there are issues of stigma, there are doubts about vaccines, there are questions about treatments, especially gynecologic treatments that involve cultural barriers of modesty. And so we need to use educational methods and reach out with groups who can provide advocacy, but who also have connections in communities, so that we can ensure that people are not held back by misunderstandings, misbeliefs, rumors, or myths. In the sixth area of action that is really essential, and Partha mentioned how important this is, we need much better data. We have very few sources of information about screening in particular. Because it's been mostly at pilot level, national health information systems often have not incorporated screening data into their routine systems. We're a little better off with vaccination data. Immunization systems are much better placed, and they also have more of an international mechanism, since immunization data is already reported annually to the World Health Organization. We need this data for monitoring, for planning, for evaluation. So it's really critical that national information systems begin to incorporate this into their routine data that is collected. And finally, we need to improve access to invasive cancer treatment wherever it's feasible. We are seeing many countries that are starting to make cancer treatment available, and wherever those sources are and resources are there, we need to ensure that women who have missed the opportunity to have their cancer prevented, who now are facing invasive cancer, that they have access to compassionate and effective care wherever possible. If these actions are taken by national governments and supported by donor and NGO partners, we can save millions of lives and greatly reduce the burden on health systems, on communities, on families, and on women. Thank you.
Thank you so much, Vivian, for a really thought-provoking presentation. So now we are ready to move into the Q&A portion of the webinar. Again, if you have a question that you'd like to submit, please use the chat window at the bottom of your screen. The first question I'm going to ask, well, the logical person, because it's a question about cervical cancer in Uganda, I'm going to ask Dr. Murakura to tell us a bit more about the programs in Uganda. Also, where Uganda has been able to scale up, or scale at least beyond pilots, what were the drivers for success for that, and where you haven't been able to scale as much as you'd like, what are some of the barriers that you have? Dan?
Yeah, thank you, Scott. I think the journey for cervical cancer prevention for us started earlier, but really recognition started being seen in 2007 when we did the HPV demonstration project supported by PATH. In that process, there was a lot of myth and misconception about cervical cancer and HPV vaccine. And so we went through a process of understanding what the key issues were in the community, within the health providers, and within the political and leadership stage. And then we did the HPV demonstration studies in 2008 to 2010, and based on that information, we started to initiate the rollout program for HPV vaccination. Initially, we extended for the 2 districts in which we worked, and then increased them to 10, and then later on, a few years ago, to all the 116 districts now. We learned from there that if you are able to engage with the community so that they understand cervical cancer as a disease that kills, and therefore can position your messaging for people to understand that the technologies available will help to prevent death, then we saw that there was acceptance in that side, both in the communities and also the leadership. And then, of course, integration of the HPV vaccine within the expanded program for immunization. Of course, initially we started with a school-based program, but eventually, because of cost, we integrated it into both school-based and the EPI program, because the overheads are now being taken care of through the normal vaccination program. So that has worked, yes, but still in terms of coverage rates, we not get it as we did when we were doing the school-based, because it's easier to get the girls in school, and most of the girls are in school, but the school-based program is a little bit more expensive than the routine HPV vaccination. But on the side of secondary prevention, HPV vaccination was the catalyst for waking up the systems for secondary prevention. Because the questions were that, so if you vaccinate our girls, so what happens to their mothers or their elder sisters or their aunties? And so we started in those 2 districts with the support of PATH and eventually WHO and several other partners, initiated several clinics. And all these were based within the government health program. And then we got more partners on, like Maristop, Space, and others, to be able to initiate screening programs across various sites in the country, both in the not-for-profit and in the government sites. But I think the major successes we saw was that we had support from the highest officers, both from the First Lady, as she was patron, and then, of course, through her husband as well, in support of this program, Ministry of Health, and other leaders in Parliament. So there was a lot of push to say the technology is available, it's affordable, let's move with it and try to see that services are available. The only issue we have had now is that we are not seeing dedicated funding specific for cervical cancer prevention. Because the way programs are funded in this part of the world is that you have basket funding, and then through the planning they are able to apportion resources to the various programs. And sometimes it becomes a problem when there are also other problems and priorities, and to say that you have only money for cervical cancer. But I believe that with more engagement, this can be handled. Through support of WHO and PATH, we have also supported various providers in country, specifically in training, in mentorships, and support supervision. And this one has been very good in ensuring that those star health workers that have the interest to continue to implement the program continue to deliver the service. The only challenge sometimes is that when health providers are posted in an area, they tend to be changed, and then your cost of training becomes frequent. So this now requires engagement with the health facility leadership and with the Ministry of Health, that those few people who have the passion to deliver the service are left to continue to do so in those areas for long enough so that they can have impact. Of course, there has been a lot of movement. Currently, we have the Uganda Cancer Institute with all this push from the political and the Ministry of Health. The Uganda Cancer Institute has its own act of parliament that designates it as the Center for Cervical Cancer, for other cancer management in the country with specific funding. And we think that was a plus on the part of government to be able to do that. And then we have also the Uganda Cancer Society that is bringing civil society organizations together that are working together to see that either for palliation, advocacy, and all these other activities that would not fit within the normal mainstream Ministry of Health, you have partners joining hands to move the agenda. But I think by and large, really the issues still remain in how we set priorities, how we protect funding for this, how we adopt new technologies and sustain them in all these countries. Thank you.
Hey, thank you very much, Dan, for helping us understand what's happened in Uganda. It's been wonderful to watch the progress over the years in your country and to see what great progress you have made. The next question is also focuses on a country, and this I'm going to ask Dr. Basu to respond, and then Vivian, if you'd like to add anything afterward, feel free. The question is, there is some skepticism about the HPV vaccine from places like Tata Memorial in India. They feel that there's not enough data to support its efficacy in the intent to treat cohort. And this has contributed to their lack of endorsement for the vaccine, which of course has influenced the national endorsement as well. How would you respond to this? Ideas, Partha?
Yeah. Okay. So we need to understand a little bit more about the analysis of the data from the vaccine studies. The studies, they have analyzed the data in terms of looking at the intention to treat cohort, which means that all the girls or the women who participated in the study and received at least one dose of the vaccine. On the other hand, there is another cohort which is known as according to protocol, which means that the girls or the women who participated in the study but were negative for infection from the vaccine-targeted HPVs, and they received all 3 doses of the vaccine. Yes, I agree the intention to treat cohort showed about 50% efficacy against high-grade lesions, but then if we look at the according to protocol efficacy, which is consistently above 90%. Now, when it translates into real-life program, in the real-life program, the WHO recommendation and different national recommendations are to give the vaccine to the pre-adolescent girls. WHO recommends to give the vaccine to 9 to 13-year-old girls, but then by and large, for all the vaccination programs, the primary target age is below 15 years, when the girls are not yet sexually exposed. So their chance of having the HPV infection at the baseline is very, very low. In that way, they simulate more of the according to protocol cohort rather than intention to treat protocol. In the intention to treat protocol, many of the girls or the women, they are already infected. And then some of them went ahead to develop the cervical neoplasias. So that is why it is always expected that the intention to treat cohort will have much lesser efficacy. So now we see that even in the real-life programs, we are seeing the high efficacy of the vaccine in prevention of not only the cytological abnormalities, but histology-proved CIN2, CIN3, which we have seen in program from Australia, we have seen it in program from Sweden, even in US, where the vaccination uptake is not very encouraging. There also we have seen significant effect of the vaccine in preventing CIN2, CIN3 disease. So that gives us quite a bit of reassurance that what we have seen in the vaccination studies in terms of the efficacy in the according to protocol cohort is really translatable in real-life program. And as you know, the responsiveness of the government to these kind of issues is very, very important. Similar thing, happened in Malaysia, where the government was very proactive, and within a few days of having a report of adverse events, supposedly because of the vaccine, government came out and clarified the issue that it was not due to the vaccine, but it was a coincidental phenomena. Same thing happened in UK and several other places. But then in India, that kind of very clear statement from the government is still lacking, and that's why there is still a bit of confusion among not only the general public, but also among the clinicians about the efficacy of and the safety of the vaccine. But then we need to understand, number one, that the vaccine has been there in the National Immunization Program for so many years now, with more than 200 million girls vaccinated. It is very clearly shown that the vaccine is safe, and the efficacy of the vaccine is not only proved in the clinical trials. Now we have the real efficacy data coming from the real-life programs showing the protection given by the vaccine against CIN2, CIN3. So I believe it is time for India, contributing to 1/4 of the global burden, to take a call on this and think about feasibility of introducing the HPV vaccine in the National Immunization Program. I understand the other priorities are also there, but then for India, I'm sure cervical cancer prevention should be another major priority.
Great. Thank you so much, Partha, for that thoughtful response. The next question I have is for Dr. Su. The question is, I know that you provide technical assistance on cervical cancer programming. If countries would like to develop new programs or scale up pilot projects, what sorts of guidance are available to them, and where can they find information or tools or get help?
Thanks, Scott. I think that there really are a lot of resources that are available now to countries, and I will shamelessly promote the fact that this journal issue that has come out has a lot of very useful practical information in it that would answer some of the questions that countries are asking. Yes, the slide is up now. There are a lot of important questions that countries need to consider when they're thinking about either starting a new program or how to scale up a program. And those choices are discussed in many of the papers in this journal supplement. But there are other resources as well. The WHO guidelines, also known affectionately as the Pink Book, came out in 2014 and give a lot of practical information. On WHO's website, there is also more information how to introduce HPV vaccine programs. There is a set of guidelines from ASCO, the American Society for Clinical Oncology, that was developed just this past year and particularly looks at guidelines appropriate to the different resource levels that countries may be facing. In addition, there are many, many resources available on the rho.org website, that rho.org. That is a website that PATH maintains about cervical cancer, but it has materials from all over the world and information that can be very helpful in a practical way. There are various organizations, including PATH, that are able to give technical assistance. And countries that are interested in that should inquire, and they can start by sending us the inquiry at PATH, but there are other colleagues at JPICO and some of the other NGOs that have been working in this area for many years that are able to provide assistance. So I think there are lots of resources available, and there are lots of good examples from neighbors in every region of the world. And we also could help people be put in touch with some of the neighboring countries that have made some of these advances and could share their experience.
Great, thank you, Vivian. And certainly both Dr. Murukura and Dr. Basu also provide a lot of technical assistance to countries. And so I'm sure they would also love to help out any way they could. The next question is quite a technical one. It comes from one of our audience members who's with an NGO that implements a HPV screening program in India. And that person asks, what threshold would you recommend? And I'm not sure who of our panelists should respond to this, so everybody please think about it. The downside of having a virtual seminar is I can't make eye contact with the presenters. But in any case, I hope someone will be able to jump in. The question is, what threshold would you recommend for treatment in patients who are HPV positive and then subsequently positive on colposcopy or VIA as well? Do you recommend using a scoring system like SWEDE, that's SWEDE scoring, or treating with cryotherapy any patients that are positive provided they do not show any evidence of invasive disease? So a clinical question. Any of our panelists ready to talk about that?
Okay, can I respond to that?
Yeah, go for it. Thank you.
Okay, I understand that what he is asking about is if the women are screened for HPV, screened by an HPV test.
Yes.
First thing is, if you have resources and the facilities, ideally the HPV positive women should be triaged with cytology. But then we understand that may not be available in many places. Colposcopy of the HPV positive women can be done provided the prevalence of HPV infection is not very high. So for example, the question is from India, where we are seeing the HPV positivity with tests like hybrid capture 2 or other screening tests somewhere around 5 to 7%. Okay, you can send these women for colposcopy. And now, as you understand, for colposcopy, the standard way of reporting is using the International Federation of Cervical Pathology and Colposcopy, or IFCPC scoring method, which includes the SWEDE scoring. So SWEDE scoring should be a part and parcel of your colposcopic evaluation. And yes, based on SWEDE scoring, one can take a decision for immediate treatment, or can take a biopsy or send the woman for management of invasive cancer. So that's on the basis of colposcopy diagnosis. But again, we have to understand that in many places, organizing colposcopy can also be quite challenging. For that, there are again two options. One can use VIA to triage the HPV positive women, or even better, there is enough evidence now that these HPV positive women can be immediately treated, which we call screen and treatment. So one has to apply acetic acid, 3 to 5% acetic acid for 1 minute, which if there is a lesion, then one has to evaluate the lesion for its suitability for treatment by ablative method. If there is a lesion and it is suitable for treatment by ablative method, it should be treated immediately either by cryotherapy or by thermocoagulation. If the lesion is not suitable for ablative method, then that lady needs a large loop excision of the transformation zone. There can be a situation where the woman is HPV positive and there is apparently no lesion. Doesn't matter. Even then, it is recommended that one should treat the transformation zone. So that is the principle of screen and treat, which reduces the number of visits. And definitely there is evidence that this is quite effective in the HPV positive women to reduce the subsequent risk of developing high-grade lesion by 70 to 75%.
I would just like to add, I think you've really highlighted, Partha, how important it is to make this decision dependent on the resources that are available. If we make a single rule about every woman who is HPV positive must have colposcopy, we will find that in places where that's difficult, women who should be treated won't be treated. And that's why I think your point about resource level is so important. And that's why the recommendation will vary from one place to another, because it does depend on what resources are available. I know that in a country in Central America that had started out with HPV testing, and their recommendation was that there should be a triage test afterwards and wait. But they found that so many women were lost that it was in the end more harmful to require that triage test than just to do, as you said, screen and treat right away. So it really does depend on the resource level that is available and what the ultimate benefit is for the population as a whole. We can make rules that are so strict that we actually restrict and create barriers for women to get care that they need.
And certainly that's been the case in some countries who for many years insisted that they only wanted to use PAP because that's what was used in the industrialized countries, and they weren't able to develop those programs, so women went unscreened. So good. Let's see. We have. I'm not sure also who might be able to respond to this. We've got a question that says that roles and responsibilities of civil society organizations often are not clear and sometimes have created conflicts with private and public sector providers in low-resource settings. Is there a way to resolve such conflicts and fix the boundaries? And I think what the questioner is asking is how can we ensure that public and civil society organizations work more closely together. Anyone have any thoughts on that? Vivian or Dan?
Yeah.
Partha?
Yeah, I could take that.
Thank you.
I think this requires the ministries of health in the respective countries to take leadership and ensure that every player in the field is implementing according to the guidelines that they have. Of course, now having the guidelines is another level. So I think the first step really is for the ministry to ensure that they have a guideline that is followed. They have active technical working groups. I think we learned from the HPV vaccination and later screening that having these discussions in a technical working group will share information and know who is doing what. And then the ministry should be able to visit their programs and assess and understand, because the role of supervision and support and quality lies within the ministries of health. So that's the point to begin. Thank you.
Anything further from other panelists?
Yes, Scott, I can give a good example from, Morocco. Morocco is, again, a developing country which has introduced population-based breast and cervical cancer screening program. And there, a synergy between the civil society and the ministry and the international organization is very nicely, organized. So they have a national foundation, which is Princess Lala Salma Foundation for Cancer Prevention and Treatment. So the foundation, the World Health Organization, and the International Agency for Research on Cancer help the ministry to develop the protocol for the program. The advocacy for the program is being done by the foundation, and the foundation and the World Health Organization, they have taken the responsibility of training of the service providers, especially training the master trainers for the program, and also to do the periodic evaluation of the program. So these are so this shows very nicely how the civil society organizations, international organizations can play a complementary role for the success of the program. So these are the issues where they can work: advocacy, training, independent evaluation of the program. Thank you.
I think this is a great example, Partha, that you give about Morocco. And we don't see such excellent examples in so many places, but I think one of the other pieces that is really important for us not to miss is reaching out to women's groups. And I think that perhaps this is related to the question that was originally raised, is to make sure that women's groups who are watching out for the interests of women make sure that they have the necessary information and not overlook the need to talk to those groups as well as just to individual women by health workers, because they are great channels for being a trusted source of information to the women in their communities. So I think that that's once we have these central guidelines from the Ministry of Health that Dan was referring to, that sets the tone and the practices that will be needed, that it's really important for us all to reach out to women's groups and faith groups and make sure that they have accurate information and that their real concerns are addressed. I know when they were introducing HPV vaccine in Zimbabwe in demonstration project, that there were members of certain faith groups that had concerns, and the government made a special point of talking to some of the leaders of those faith groups so that their concerns could be addressed and they could end up supporting the program rather than raising questions about it.
Great, thank you. We have another rather technical question. I hope one of you or more will have a thought on it. The audience member asks, do you have any opinion on the different types of mobile colposcopes? And particularly they're thinking of mobile ODT versus the gynocular colposcope. Anyone want to or feel like you can weigh in on that one?
We evaluated gynocular in a field setting. Essentially, every device has its plus point and minus point, and I will not really call these devices alternative colposcopes. They are essentially magnifying device with good light source, and most of them are battery driven. So these are advantages in certain settings. And ultimately, to do a colposcopic evaluation, what we understand by colposcopic evaluation is looking at the cervix and trying to diagnose a disease. It is all dependent on the provider's the experience and then the training. Having said that, I think for this kind of equipment, there is a place to use them by the VIA providers in a screen and treat setting to identify the squamocolumnar junction and to decide on the suitability of the lesion for immediate ablative treatment. So it has not yet been evaluated in that context, but I think having used that in a field setting, I think it has a place in doing that.
Great, thank you, Martha. Dan, Vivian, any thoughts?
Yeah, I think that one of the questions that we always ask ourselves about all of these new technologies is to weigh the cost against the benefit. And so we identify the benefits, and the manufacturers are very happy to tell us about the benefits. And in certain settings, they really will be very valuable. And then the other question is whether they displace other resources that are needed by the cost that is attached to them. And if that, that's the balancing that we need to do of benefit and cost. If there are resources available and these add sufficient value, as Partha describes, in making it easier to visualize, then those programs may benefit, especially during training or perhaps during referral services. That might be the first places you would use these extra technologies. But in settings where where we're doing screening at the primary care level, and may not be able to put in, several $100s for devices, then that may be the trade-off that programs have to ask themselves.
I think also, yes, thank you, Vivian, for that aspect on training. Also, I think in areas where you have many health providers out there working on their own after training, and you don't have enough supervision to ensure that the quality of the VIA exams is as it should be. So if there is a way that one can be able to have some of these devices on the quality assurance side, to ensure that for a sample of women, you are able to check on what they are saying. But of course, this still comes to the issue of cost. So one has to gauge and say, how much can I do to be able to ensure that the skill level in these providers in identifying high-grade lesions and the decisions they make is checked on. Thank you.
Thank you, Dan.
Can I just add one more point? Because,
sure,
Dan,
sure.
you stimulated a thought. It comes back to the issue of data, that one of the biggest problems, I think, for our providers who are trying to do VIA is they get very little feedback to what actually happens. And that is one of the things where supervision, where training, where we would need to try and find better ways to give feedback. And some of that can come through our data systems, improved data systems, and some of it may come through some of these devices, particularly the ones that use phones or cameras to take pictures as a record, as long as those pictures are then used to ensure that feedback is given to the provider who took them.
Yeah.
Okay, good, thank you. I don't see any more questions from the audience. Do any of you, Vivian, Partha, or Dan, have any last words or other things you'd like to mention before we call it an evening? Okay, then. I want to thank Dr. Daniel Murakura, Dr. Partha Basu, and Dr. Vivian Su so much for their thoughts and expertise today. And I want to especially thank everyone who logged into the webinar for your interest. Again, we will be archiving this, and you'll see an announcement about how to access it if you'd like to come back again and relive the experience or share it with friends and colleagues. Thank you so much, everyone. And for me, it's good night, and have a great day if it's not quite dark where you are. Bye-bye.
Yeah. Okay,
Bye.
thank you.
Bye. Thank you so much, Scott. Yeah, bye.